it's important for us at the North American Thrombosis Forum that we not just produce a very science-heavy session. We want to make this accessible to all of our patients and to providers. In the end, we're all patients, and we all have to take part in some way in our own care. And so this afternoon's session is going to help us understand the little things that we can do in our daily lives to lower our thrombosis risk. Yes, it's very important. Last night we talked about patient advocacy and taking your medications, adherence to medications, dealing with the cost of medications. All of those things are important, but there are also things that we can do every day, like healthy diet, exercise, understanding the role of cardiac rehabilitation for patients that have cardiac issues. All of these things are important, and they can reduce our risk further than what medications alone can provide for us. So we've assembled a fantastic panel of speakers that are going to help us arm ourselves so that we can all reduce our risk. And I want to take a moment to recognize our generous sponsors for this program, Janssen, Boehringer, and Daiichi Sankyo, who have given us the ability to provide you with this tremendous program. And so with that, I'd like to start with our first speaker, Dr. Christian Ruff. He's a close friend and colleague of mine, instructor of medicine at Harvard Medical School. He's a staff cardiologist at the Brigham, and he spends a lot of time in his research career focusing on how we can better lower the risk of stroke in patients who have atrial fibrillation. And he's going to speak to us now from the point of view of, I have atrial fibrillation, what can I do to lower my risk of stroke? Christian, thank you.
Thank you very much, Greg and Sam, and welcome to those meeting for the first time today and those back from this morning's session. And this morning we've heard a lot about risk stratification for stroke and anticoagulants with a focus on the novel anticoagulants, and we're going to talk a little bit about that today, again, because when you have atrial fibrillation, medical therapy, specifically antithrombotic therapy, is very effective and needed in most patients with atrial fibrillation, but I'd like to provide a little bit of a broader framework about what are some of the other things we could do, and do those things work, and then really who should be receiving these anticoagulants. Maybe some patients with atrial fibrillation don't need this escalation of therapy. So all of you know that atrial fibrillation, it's an important topic to talk about because it's incredibly common. It's by far the most common arrhythmia we see in clinical practice, and it's characterized by having an abnormal electrical system of the heart. Instead of a nice orderly heart rate, you have a chaotic atrial activity, which often leads to very rapid heart rates. Now, the complications of AF really fall into two broad categories. One are the hemodynamic ones, and these are often how patients present. They're short of breath, they're fatigued, they maybe sense palpitations from an irregular and fast heart rate, and of course there's an inextricable link with heart failure. Patients with atrial fibrillation are more likely to have problems with fluid retention, and patients with heart failure are more likely to have atrial fibrillation. So that's one component. We need to treat the symptoms of atrial fibrillation because that helps patients feel better. But as physicians and healthcare providers, sometimes we worry more about the other consequences, which are the cardioembolic. And that's generally stroke or systemic embolism. Unfortunately, if the heart ejects a clot, the first big organ that it sees is the brain, which gets the majority of your blood flow. So when you have a clot in the heart from atrial fibrillation, you're much more likely to have a stroke than you are from any other embolic event, although the rest of the body can be affected. Why do we care so much about stroke in particular? Partly because we know atrial fibrillation, on average, increases the risk of stroke about 5 times that of a patient the same age, the same gender, who didn't have atrial fibrillation. Now, the underlying risk varies considerably, and Sam talked about it this morning, and I'm going to briefly go over that again. But depending on your underlying risk factors, you could be at a higher or lower risk of stroke. We care about strokes from atrial fibrillation because strokes of all kinds are devastating, but strokes from atrial fibrillation are generally the most severe. They're more likely to be fatal, and they're more likely to be big strokes that lead to permanent neurological devastation. The costs are really quite staggering, and we know this is quite common. that 1 in 5 strokes, all comers, are due to atrial fibrillation. If you look particularly in patients who are 70, 80 years old, 1 out of every 3 strokes is likely due to atrial fibrillation, and that number, it keeps on climbing. Now, the treatment of atrial fibrillation falls into 3 broad categories, and we're going to spend some time talking about all 3, but as I previewed this morning, more time speaking about antithrombotic therapy. But in addition to antithrombotic therapy, there's, of course, rhythm control, trying to get patients out of atrial fibrillation, and rate control, slowing the rate. Now, it seems to make sense that if atrial fibrillation is bad for you and causes strokes, that getting people out of atrial fibrillation must be good for you. That seems very obvious. It turns out that it's not quite simple, and in fact, it doesn't even appear to be true at all. And when they did a large-scale trial, and this was an AFFIRM trial, they showed that if you took patients with atrial fibrillation and randomized them to leave them in atrial fibrillation and just control their symptoms, or try to get them out of atrial fibrillation, predominantly using drugs to help them put them in a normal rhythm, not only was getting them in a normal rhythm not better, it actually tended to be worse. Patients who you tried to get out of atrial fibrillation, actually there was a trend towards increased death. So that's really not what you want to see when you run a clinical trial. And what happens if you look closer at the details is nearly 3/4 or 75% of strokes that occurred in these patients were due to discontinuation of anticoagulation. And most of the strokes, a large minority of the strokes, 42%, occurred in patients while they were not in atrial fibrillation. So what happens is, if you use an antiarrhythmic drug or a cardioversion or an ablation, you may think that you cured atrial fibrillation. But these patients are often going in and out of atrial fibrillation in their home. They have no idea, you have no idea. So you pat yourself on the back, but really these patients are still at an elevated stroke risk. And what's the most dangerous thing that you can do for those patients is stop anticoagulation, because then they're not protected. And so this really is a paradigm shift in the thinking, is that once you develop atrial fibrillation, for as far as we know, you're at risk for stroke regardless of actually if you remain in atrial fibrillation. The other part of this was, well, we know patients who present with atrial fibrillation are often at a very rapid heart rate. Maybe if we slow it down, that would somehow reduce events. And we've used to be much more aggressive in controlling the heart rate, and this is at a race too. And we've learned we really don't need to do that as well. If you have more lenient rate control, making sure that patients don't develop a heart rate above 110 beats per minute with at least sort of moderate activity, that's probably good enough. We don't need to drive everybody's resting heart rate to 60 beats per minute. In fact, patients tend to feel poorly when their heart rates are too low. Now, whether this data also applies to patients who have a weak heart, who have heart failure, that's not as well known. But for most patients, I think we can be more liberal about their heart rate control. But unfortunately, whether you aggressively control the heart rate or you try to get them out of atrial fibrillation, that does not appear to reduce your risk of stroke at all. So then we're really stuck with antithrombotic therapy. I wish I had an easy message for you that if you exercised more, and you ate the right foods, that your risk of stroke goes down. But for atrial fibrillation, unfortunately, really the bulk of your risk reduction is going to come from taking a medication. Now, that medication is an antithrombotic agent, and antithrombotic agents come in 2 distinct flavors. There's antiplatelet agent. An example of that is aspirin or clopidogrel. You heard a little bit about that if you were here this morning, or one of the other agents, or an anticoagulant. And the anticoagulants are warfarin or some of the new agents that we spoke about this morning, dabigatran, rivaroxaban, apixaban, and potentially edoxaban. And I think Dr. Mega showed this slide this morning, that really anytime you give an antithrombotic, which is a blood thinner, you are hoping to prevent ischemic events, but you will cause bleeding. And as I said this morning, if you give an antithrombotic drug and it doesn't increase bleeding, it means that they're not taking it. All antithrombotic, if you prevent clotting, you're going to cause bleeding. So it's a risk-benefit that has to be individualized for specific patients. We often heard that I have atrial fibrillation, but I'm not at a high risk of stroke. I hate taking warfarin. I just want to take aspirin. Maybe I just need to take a baby aspirin. Well, we did that for a long period of time, and that was actually in the previous iterations of the guideline. It turns out that that may be very good for coronary disease and heart attacks and stents. Doesn't appear to hold muster with atrial fibrillation. In fact, in the latest literature, aspirin appears to be not effective at all in reducing stroke for atrial fibrillation. This is a large study done in over 132,000 patients, observational study, that warfarin cut stroke rates by about 40%. Aspirin had no effect on stroke rates. And more alarmingly was we always think that, well, aspirin may or not be as effective, but it's certainly safer than warfarin. At least in the AF population, these patients had the same rate of bleeding on an aspirin as they did in warfarin. So aspirin is not necessarily a safe medication. Aspirin causes a lot of bleeding. And in this population, aspirin caused very similar bleeding, specifically major bleeding and intracranial hemorrhage, as warfarin. So it becomes challenging to prescribe aspirin when it's not effective as warfarin. It may not be as effective at all, and it causes the same amount of bleeding. So aspirin for stroke prevention and atrial fibrillation is rapidly falling out of our guidelines. So I told you this morning that warfarin is quite effective. It's a terrible drug to use sometimes, but it reduces stroke on average by about 60+%. And then we heard this morning that although we only had warfarin for half a century, now have 3 additional agents for stroke prevention and atrial fibrillation. And just to summarize for those who weren't at this morning's talk, these new agents are as good or better than warfarin in reducing ischemic stroke, but they're much better than warfarin in reducing hemorrhagic stroke. Drops that rate by 50%, so a major, major advance. And it appears to be much safer than warfarin. So often when we develop new drugs for cardiovascular disease, they tend to be more effective but also less safe. So you don't get a free lunch. You got to choose between one or the other. I think with the NOACs, it's one of the few medications, the novel oral anticoagulants, that you almost do get a free lunch, where it's as effective or more effective, but actually much safer with respect particularly to intracranial hemorrhage, which is the real contraindication that we fear from anticoagulation, because we know bleeding into your brain is often very devastating. Sam spoke to you this morning about, okay, you've convinced me that I can't just control the rate, I can't just convert them to sinus rhythm, I have to give something. Aspirin doesn't appear to be that effective. Now I'm stuck with warfarin or one of these new agents. Am I really going to be giving that to everybody with atrial fibrillation? And the boundaries are changing rapidly, and we now realize that we should be anticoagulating more and more patients. If you use the old CHAD score, about 40 to 50% of the patients you see in clinical practice, you would not anticoagulate. Their CHAD score would be too low. In these new scores, it's trying to take those patients you wouldn't anticoagulate, a CHAD score of 0, and figure out, are they really truly low risk? Because there are patients with a CHAD score of 0 that have almost a 3% stroke risk per year. And there are others who are truly low risk, approximately 0% per year. And what the CHADS2 VASC is, it sounds very similar to CHADS because it has all the CHADS component, but it adds other things like being a woman, a slightly younger age, having vascular disease that we know also increase risk, because now you pull out those CHAD0 patients and you separate them to a CHADS VASC of 1 to 3. And truly patients with a CHADS VASC score of 1 are so low risk, you probably don't need to be doing anything for them. And almost everybody else is at a decent enough stroke risk that you have to at least think about anticoagulation. Because remember, they're going to accumulate that stroke risk every year that they're alive, and your stroke risk only gets higher with each passing year. Now, because there's a benefit risk, people will always say, well, I know they could be at risk of stroke, but maybe they're also at risk of bleeding. And we need a risk score for that. Now, it turns out that the same patients who are at risk of stroke are the very same patients who are at high risk of bleeding. Look at the HAS-BLOOD score. It has a lot of the same features: hypertension, prior stroke, elderly. And so you're really against a rock and a hard place, because it's not like the young, healthy patients are at a high risk of stroke, but a low risk of bleeding. They tend to follow each other. And this HAS-BLOOD score has been developed to help clinicians figure out the benefit risk of anticoagulation. Now, I'll be honest with you. In my opinion, you should not use the HAS-BLOOD score to not anticoagulate a patient. And so there are almost no patients that you can find where their risk of bleeding outweighs their risk of anticoagulation. It's actually very hard to do. And so that's why the European guidelines now have moved towards recommending anticoagulation in all patients who have at least a CHADS-2 VAS score of 1. And these new agents appear to at least be much safer than warfarin, so if cost isn't an issue, I think it's reasonable to consider. But probably the most important thing is that we anticoagulate more people. What you want to be anticoagulated with, I think, is a dialogue that's much more complicated and it's individualized for specific patients. Because if we look at really where's the failure, and Sam, I think, very poignantly shows that there's a massive failure to prophylax, that people decide to not anticoagulate for real contraindications or the patient doesn't want to take it, but most often because we decide a patient is frail or they're elderly or a history of falls. And just one caveat, they've calculated that this frail patient who falls, and this is a neat statistical exercise, that a person taking warfarin has to fall approximately 300 times in 1 year for warfarin not to be effective in that patient. So we grossly overestimate the risk of bleeding with falls, and the fact that we withhold anticoagulation from people who need it because of fear of bleeding is usually overstated. And when we talk about risk-benefit, I think it's very sobering that if you treat 1,000 patients with atrial fibrillation with warfarin for 1 year, not even the new agents, just with warfarin, you prevent 35 fewer strokes, essentially. They're mostly strokes. And you'd only increase the risk of intracranial major bleeding by 1. That's a 35 to 1 benefit. So I think that as a society, we have to become much more comfortable that anticoagulation for stroke prevention and atrial fibrillation is incredibly necessary, and it's hard to get around it. And how do I use a Hasbled score? I don't use the Hasbled score to withhold anticoagulation. I look for things that I could stop in that patient to reduce the risk of bleeding. Drugs and alcohol, that's nonsteroidal anti-inflammatory drugs. Aspirin, can I stop those drugs? Because when used with warfarin or a novel agent, dramatically increase risk of bleeding. Are they hard to control on warfarin? Is there INR all over the place? 6 one day, 0.5 the next. Switch that patient to a novel oral coagulant. Do they have untreated hypertension? Because we know that the higher your blood pressure, the higher your risk of bleeding, particularly intracranial hemorrhage. So I used a Hasbled score not to withhold it, but to modify things in an individual patient to lower their risk of bleeding. So to conclude, unfortunately, I wish I could tell you there was another answer, but anticoagulation for most patients is the most effective way to lower stroke risk. But the decision is an individualized one, and it has to be made with the healthcare providers, nursing and pharmacists and patients, and you have to weigh risk of bleeding, risk of stroke. And in general, I think we tend to overestimate bleeding risk with anticoagulation. That's been a real failure of ours as a medical community. And I think over time, you're starting to see a refinement of these risk prediction strategies, and more patients, I think, will be eligible for anticoagulation in the future. Thank you.
Thank you, Christian. That was great. And so we've designed this afternoon to make it very interactive. Come up to the microphones, state your name, and pose your question.
My name is Ed Foster. I take 420 milligrams a day of diltiazem, and when I have an episode about once a month where I have an AF, and my doctor has me take 60 milligrams every hour to try to help get back to normal. But from what you said, it doesn't make any sense to do that. It's better not to worry about the atrial fibrillation event. It'll just go away anyway within a day or two.
Yeah, no, I think and just to rephrase the question, you asked for bouts of symptomatic paroxysm of atrial fibrillation. You'll take more of your heart rate medications to slow it down. Yeah. And you're asking a question, should I be doing that? And that's necessary. And I think you asked, it's a great question because what you're doing makes perfect sense, but you have to realize if it helps you feel better. So there are patients when they're in atrial fibrillation, they don't even know they're in it. And if it didn't bother you to have a faster heart rate, then I think there's not a particular benefit of aggressively treating it with heart rate lowering medications. But if you were to be symptomatic and there are people when they're in atrial fibrillation that's uncomfortable, they feel their chest pounding, then by all means, be very aggressive in getting it down or converting it to a normal rhythm, but just realize that that doesn't necessarily change your stroke risk. And so whether you have atrial fibrillation for 10 minutes every couple of months, or whether you're in atrial fibrillation every second of every day for the rest of your life, as far as we know the data now, for the most part, the stroke risk is the same if the patient has the same underlying risk, they're the same age, they have the same, clinical characteristics. And so the treatment of symptomatic atrial fibrillation is just that, to control symptoms. It doesn't appear to affect their risk of stroke. So if you feel uncomfortable, by all means, take more diltiazem. But if it doesn't bother you, then there's not a particular benefit for you.
Great. Thank you very much.
We have time for a few more questions.
Hi. My doctor, I have a new one now. The one I had before had me on warfarin and aspirin. Now, from what I've just learned, that's not the optimal way to treat my condition, which is called sudden unprovoked blood clots. So I have a new primary care doctor now. Do I tell him that I went to a seminar and I learned that what I was doing, I'm taking warfarin and aspirin, I should change? How do I tell him?
This is a great question. It's almost like I planted you in the audience. And I wish I had spent more time in my talk, because I think that's the critical question. What we often find is that patients end up on both warfarin and aspirin. And the part you said is absolutely true. When you are on warfarin or aspirin, your risk of bleeding is significantly higher. In fact, it's exponentially so. When you put them together, it's not just simply additive. The risk of bleeding shoots up. And most patients with atrial fibrillation don't need to be on aspirin. Now, my easy answer, and I don't know the sort of the full background on your medical history, that in most patients, unless they have another reason to be on aspirin, that they have a prior heart attack, they've received a stent, a coronary stent, that if they have another indication for that aspirin, then unfortunately sometimes you have to accept the excess bleeding risk. But if they just have atrial fibrillation and they just need a blood thinner, you only need one, and that one should be warfarin or a novel agent, and aspirin should be discontinued, because the aspirin will only increase your risk of bleeding and will have very little benefit for stroke prevention. So I think that's a healthy thing, and I do that with my patients. When I see them with atrial fibrillation, I say, why are you on the aspirin? Do you have coronary disease? Did you have a heart attack, a stent? And if not, I pull it off, because I'm not doing them any favors, and they're at risk for very high rates of bleeding.
Yes, sir.
Hi, my name is William Hahn, and my wife has had AFib for how many years? 10 years? 11 years, okay. Now, she was given, dabigatran?
Mm-hmm.
Yeah. Dialyzer and which one? They are the same? Dialyzer and dabigatran?
Diltiazem is a drug that'll help control the heart rate.
Right.
And then the dabigatran is one of the new blood thinners that replaces warfarin.
Yeah, it was approved 1012.
A couple of years ago.
Yeah. October 18th. I even remember the date.
Oh, wow, yeah.
So far, she's doing good, okay? But you mentioned fatigue, right? She feels fatigue, okay? Usually, she will take a nap every day. She's been retired, okay? And that helped her a lot. Now, I'm thinking this dabigatran is new. Is it safe?
Yeah, and I think that's a great question. You're wondering, the dabigatran is a new agent. These novel blood thinners are all relatively new. We have less clinical experience with them. And I think it's an excellent question. Now, these trials that studied all of the agents are very big trials, some of the biggest that we've ever had in clinical trials. And they've also been on the market now several years, and the FDA and other regulatory agencies have looked at them. And these drugs appear to be extremely well tolerated. They all can increase the risk of bleeding. That's true with any anticoagulant. But to my knowledge, none of the new agents have been particularly associated with fatigue. And so I think that being tired is a very common symptom, and it may be more related to the atrial fibrillation and potentially how fast that heart rate is. But I think it's probably unlikely to be related to the bigotry. And not that that's impossible, but there doesn't appear to be a signal that these drugs cause increased fatigue compared to, say, warfarin or even taking nothing.
Yeah, there's one more question, because she's a little bit, she's not young anymore. She's, I don't want to say, she'll get angry with me, but for her age.
You're in trouble now.
May have to take a cab home.
That's going to be a bad ride home.
Yeah.
See, I follow her everywhere. I even took her wallet. So I hope she's okay. So thank you very much.
You're welcome.
Christian, I had one, if briefly you could, we've hit on it a couple of times in the morning session that monitoring for asymptomatic episodes that might happen in the middle of the night using heart monitors can help us to parse out which patients are at higher risk for strokes. We know the patients that don't have episodes of atrial fibrillation at night or at other times when they don't suspect it do better. Can we use monitoring of asymptomatic AF to decide whether we should be anticoagulating or not? Is that on the horizon?
Yeah, and I think that's a great question, and this is one of the big controversies in medicine, because as I told you before, it didn't seem to matter how much atrial fibrillation you had, that your risk of stroke was similar. But that was really in patients who came to clinical attention with atrial fibrillation. So they developed a rapid heart rate, went to their doctor or the emergency department. But now with these new devices, we're able to detect fast heart rates, which may or may not be atrial fibrillation. The patient doesn't feel anything for very short periods of time, seconds to even minutes. And what's the threshold? How long do you have to be in atrial fibrillation? 10 seconds, 1 minute, 6 minutes, 2 hours before your risk of stroke goes up? The true answer is we don't know. There's been very intriguing data that being in a fast heart rhythm, atrial fibrillation or an early precursor, for as little as 6 minutes, even if you don't feel it, could increase your risk of stroke. Now, maybe you're not at the same risk as someone who has clinical atrial fibrillation presented to their doctor, but not zero. And so now these studies are being done where we're looking at people who get monitors for other reasons or even implanting them to look and see what is the threshold, because, and I think in the future we likely will say that there's probably an increased risk, and for some patients we may even be providing blood thinners for patients with asymptomatic atrial fibrillation. Now, whether it's going to be the same dose or we're going to have to weigh bleeding more seriously in those patients, I don't know, but I think it's a very relevant question. And my big picture is we're going to be anticoagulating more and more patients, because right now I think it's safer to anticoagulate patients than it's ever been in the history of medicine.
Thank you, Christian.
Great.
That was
Thank you.
wonderful. Thank you.